Hi, my name is Christian Scharenberg. I am a hematologist based in Skövde, Sweden, and I was one of the founding members of the Young EHA committee. And I'm here today with David Rees to talk about sickle cell disease and precision medicine. Could you introduce yourself, David?
I'm David Rees. I'm a paediatric hematologist at King's College Hospital in London with a main interest in sickle cell disease and other inherited red cell disorders.
Could you give us a definition of precision medicine and explain how this concept can be applied to sickle cell disease?
Well, I think it's a difficult term to define precisely, at least for me. I think it's become a fashionable term really over the last 10 years, driven by advances in genomics and bioinformatics and the basic idea that you can, even when someone has the same disease, you can identify different groups within that disease that can be treated differently to get better outcomes. As I said, it's driven really by that is a fairly simple principle that has always applied to medicine, that you try and treat people in the best possible way for their disease. But it's been driven really by, high throughput genomics, particularly in the malignant field, and in hematology, particularly in AML and other conditions where there are clones with a lot of differences. And then it's become more widely applied to anything that you want to make sound interesting. I think in the context of sickle, it's not very obvious. I think it's a useful idea to think about, but at the moment it's difficult to apply it very precisely because sickle cell disease is, genetically it's all the same, although there are obviously, there are other genetic differences between individuals that means the disease is expressed differently. So there's certainly scope for developing it in sickle cell, but at the moment there are few treatments really, and there isn't a good way of predicting prognosis. So I think it's a useful thing to think about and to work towards, but it's nothing like the situation, say, in some malignancies where you have a huge range of different treatments and a huge range of different diseases which you can try and fit the treatment to.
What are the main prognostic factors and biomarkers?
Well, in sickle cell disease overall, if you had to choose one prognostic factor, that would be where you live. So if you live in an African country, then your outcome is so much worse than if you live in a high-income country. As in a low-income country, where in most African countries it still seems that more than 80% of people die in childhood. Whereas, say, in London, in sickle cell disease, that is a very rare event. The childhood mortality of sickle is only slightly increased compared to the baseline population. And obviously that's not a genetic difference, that these are genetically more or less identical populations. This is to do with access to healthcare and more, not even medicine really, but socioeconomic factors. Within sickle cell disease, where you're looking at high-income groups, then there are some factors that there are different types of sickle cell disease, and if you have SS, sickle cell anemia, you do worse than if you have SC, say, a less severe type. And there are some more traditional genetic factors which can be identified and do influence outcomes. Particularly alpha thalassemia has quite a profound effect on a lot of manifestations of sickle cell disease. And in African populations, about 30% of people carry that. So it is possible to look at that and to give parents or patients some prognostically useful information. It's not useful enough to say, you will live this long or you need this treatment and you'll do better. But it is treatment that is, it is information that is useful at this stage. There are other factors that people have looked at. And the hemoglobin F level is another quite important determinant. And if you have more hemoglobin F, you're more likely to do well and have fewer problems. In general, that's something you measure biochemically. It's not necessary to do genetic testing, although there are genetic tests which predict hemoglobin F levels, but those are in fact less useful than measuring the hemoglobin F level itself.
What are the main drugs currently available? Because I think some of them actually work to increase hemoglobin F, right?
Yes, exactly. I think one problem with precision medicine and sickle is there aren't that many drugs available. The most universal drug is penicillin, which is given where available to everyone to prevent early childhood death from sepsis. And then, as you said, hydroxyurea is the other drug that is currently, there's good evidence really that pretty much everyone benefits from taking it from an early age. And that works primarily by boosting the hemoglobin F level, which reduces the rate of sickle polymerization, which has a profound impact on all the manifestations of the disease. And that, as I said, again, in terms of precision medicine, the fact those drugs are pretty much given to everyone, so it's not really, it doesn't fit the precision medicine model very well. There are a few, although sickle cell disease is very common and an old disease, there have been very few diseases, but in the last 5 years, then there have been 2 or 3 other drugs emerged which have been licensed in some countries and will be licensed in others, those being crizanlizumab, which is a P-selectin blocker and reduces frequency of pain, and L-glutamine, which is meant probably provides some sort of antioxidant protection and has a weak effect on the frequency of pain. It's been licensed in the States, but not been licensed in Europe, and because of people or the EMA not being convinced by the clinical trials, and it seems unlikely that will become available in Europe. And a third drug, voxelotor, which binds to hemoglobin and increases the hemoglobin level by increasing the oxygen affinity, which is an interesting drug and certainly has an effect on the hemoglobin level, but it's not very clear what clinical benefits it gives at the moment. I'm sure it probably has some clinical benefits, but those are yet to be defined. And it may well be that voxelotor is a drug that, where you can be more precise, that seems likely some patients will benefit from it more than others, but at the moment we can't predict that.
And hydroxyurea, which is the mainstay even at the moment, that was a serendipitous discovery, right?
Yes, definitely. It was found. It was really used initially in trial of other drugs in the 70s to promote hemoglobin F, and it was chosen as a safe option because it's relatively non-toxic as these drugs go, and it's cheap and already available. And in fact, it did as well as the drugs they were testing, and it was taken on as the drug to be developed rather than the drugs. I mean, it is a very effective drug. It has a profound effect on hemoglobin levels, and almost everything you can measure in sickle, every outcome it improves, and that's been shown in high-income countries and low-income countries now. Having said that, it's not curative, and it's borderline transformative. I mean, it is an important drug, but it's not like this is so good we don't need anything else. It's better than not having it, but there's a huge amount of scope for improvement.
Yeah. So do you think a precision-based medicine approach will become feasible, and even in low-income countries? Or?
I don't know. I probably lack imagination. I think at the moment, the hydroxyurea and penicillin are cheap. The other drugs are expensive. They're, £100,000 a year or something. So the idea of even multi-drug therapy or precision medicine in high-income countries is barely affordable. So at the moment, it's a million miles from being affordable and applicable to most of the people with the disease, more than 80% of whom live in low-income countries. I think things will move on, and there will be, the drugs will become cheaper and there'll be more drugs available, and people are working specifically to develop, small molecules which are cheap and can be used in low-income countries. So I think it probably may happen, but not in the current form in which it's used in say, in leukemia, where you have, I think high-throughput genetic sequencing, again, from the millions of people in Africa with sickle cell disease is a very, very, very long way away, and probably will not become necessary because curative treatments will mean that you cure everyone, so it becomes less important to identify prognostic groups then.
And you think that'll be gene therapy based?
Yeah, I think so. I think that's the aim. Gene therapy is still at a very early stage, and there are encouraging trials in high-income countries showing benefits. I think it still is a long way from being a widespread treatment. It's still very expensive and not affordable in most countries. But I think there are developments with in vivo gene therapy and direct correction of the sickle mutation, which you can imagine would potentially offer a curative, fairly cheap option for pretty much every patient with sickle cell disease. Although obviously that's a very long way away, and maybe, I think may not be possible. People are dubious about whether in vivo gene therapy will ever be effective. But whilst currently it requires myeloablative treatment, and that is always going to limit its applicability to most people in the world.
Where do you see sickle cell management will go in the future?
Well, I think in the distant future, I really do think that probably is what will happen, that there'll be a relatively simple in vivo treatment that, that cures the sickle mutation, corrects the actual genetic defect, in the medium or long term, that is easy to administer in the same way that vaccines are. In the shorter term, I think, there was, if you looked at how to improve most people, so, simple public health measures and availability of, although hydroxyurea is effective, it's still not available to the vast majority of people in the world with sickle cell disease. So if you had to do one thing to improve people's health now, it would be, to work out ways of making that more available and more affordable, although it's not an expensive drug. In the medium term, I think the new drugs like crizanlizumab and voxelotor may have a role, but I think if you accept that the goal is to cure everyone with sickle cell disease, then the disease-modifying treatments are not they're useful and maybe they lead to better treatments, and there may be small tablets that are very effective, small molecules that are very effective at treating the condition. But these drugs, I think, are on the way to developing that. They're not the final solution.
Wonderful. Thank you so much.
Thank you.